So if you happen to be in front of a computer, please click that link that I sent out. If not, I had also emailed out the attachment, the presentation and an attachment, so you can reference that. And I wanted to, it's with great pleasure this morning that I get to introduce our presenter, Dr. Claire Davenport. Claire is a geriatrician and bioethicist. She is an attending physician and assistant professor with the hospitalization at home team at Icahn School of Medicine at Mount Sinai. Claire completed her undergraduate degree in chemistry at Skidmore College and her medical degree at Albany Medical College. She then completed internal medicine residency and a fellowship in geriatric medicine at Albany Medical Center in upstate New York. During her internal medicine residency, she completed her Master's of Science in Bioethics. I guess the internal medicine residency wasn't challenging enough. We also need to do a master's with it. Her thesis was on supporting patient autonomy and the moral imperative to screen for mild cognitive impairment. Her publications have focused on prognostication, I did have to look up how to say that, and rehabilitation. She previously worked with a program for all-inclusive care of the elderly before joining the novel hospitalization at home program with Mount Sinai. She's a clinical educator who seeks to train workforces that support aging in place from home health to support ADLs and IADLs to primary care, acute medicine, and rehabilitative services, including subacute rehabilitation in the home. And on a personal note, Claire did not include this in her bio, but she happens to be an incredible weightlifter and fitness guru, and I have the privilege of training with Claire on a weekly basis. So I just wanted to share that as well. And now, Claire, I'm going to turn it over to you.
Thank you so much, Adina. It is my pleasure to be here. This is exactly the sort of audience that we are hoping to reach as a group with the Mount Sinai Hospitalization at Home program, as we're looking at a future of medicine and what it looks like, especially for services like yours that have really made headway into what it looks like to deliver home care at its highest quality. Thank you for that wonderful introduction, Adina. It's my pleasure to be your trainer. So the overview of my talk today, it's going to be half an hour long. I promise to keep to that. I'll give you some background on our program and hospital at home in general, some data, give you an idea of what the model looks like, but use a case to show it. And then we'll talk about the challenges and the future of this model. These are the objectives for my talk. I'm not going to belabor them, but within them, you're going to learn about the hazards of hospitalization, and you'll learn about our outcomes. I don't have any disclosures. I'm going to start here. So hospital at home is really formulated around a geriatric care model that incorporates an interdisciplinary team. And the reason why that's relevant is that outcomes for patients who are 65 and older are really what we're seeing a lot more of in the hospitals themselves and analyzing in order to understand how hospitals are serving or potentially causing harm to patients. So this population is the population that we really should be looking at as the indicator species of the healthcare systems and whether or not they're delivering the optimal care or not. The hazards that we see in traditional hospitalization include functional decline, malnutrition, delirium, adverse drug events, nosocomial infections, and this is only a small set of them. But I do want to call them out. Functional decline, as many of you know, when your patients are getting out of the hospital and you're beginning to see them as a part of a community health group, as a part of their discharge, 34 to 50% of inpatient general medicine patients lose one or more activities of daily living during a stay. And the more that they lose, the longer their hospital stay is, and the more likely they are to require long-term placement, and they have an increased mortality. Malnutrition is extraordinarily common, especially in the older age group. They come in malnourished, and then they experience nutritional deficiencies during their hospitalization. Delirium is something that is considered preventable when it occurs in the hospital. It has a lot to do with the environment, waking people up at night, giving them the wrong medications, and it can occur into 20 to 30% And it's an incredible cost to the patient that this occurs, including cognitive impairment that can last up to 9 months. It can be the onset of from mild to moderate dementia, and it can result in mortality and increased costs. Adverse drug events are also very common in the hospital setting, and nosocomial infections can further complicate their courses. So might it be possible to disrupt the system and think about other ways of delivering hospital-level care and other potentially safer places, depending on how you build your model and consider the quality around it? So this is exactly what Dr. Less and his group at Johns Hopkins did. They received a grant to look at hospital at home and try it out. They did a 17-page pilot, and they showed that it was feasible. A larger national demonstration study followed, and then it continued to expand in the later to 2014 to the present. In 2014, we actually received a grant from CMS, an innovation grant, and we looked at a 30-day bundled payment model for fee-for-service Medicare patients. And we also developed some contracts with insurance companies to see patients. During that time, we saw 295 patients, and we were able to match them to controls. And we'll talk about the outcomes of that data. And then the end of the grant phase occurred in 2017, and then we had to think about how do we make a sustainable business model out of hospital at home. And I'm going to speak to some of those challenges that we faced, but we are up to 820 patients at this time. So the Johns Hopkins model, just to give you an overview, we would assess the patients in the clinic or at the ED. They would then transport them home in an ambulance. In the home, they would receive care from a nurse, from the interprofessional team. At some points, we were including home health aides in the benefit we were offering, and then we would discharge them. So they're not being discharged from the hospital, rather they're being discharged, but they basically stay at home. But now their primary care provider receives them back and is in charge of their care. The outcomes are really impressive. It's feasible, efficacious, high quality. A lot of patients choose it, 61 to 93%. There's a shorter length of stay compared to hospitalization, 3.2 to 5.5. There's reduced cost, about $2,500. In our model, it's $1,700 less per admission. Fewer readmissions and bounce backs. We have improved ADLs and IADLs, speaking back to how patients lose so much in hospitals. Improved mortality, that's an international study. We haven't had the numbers in the US to show the same. It's certainly not more mortality, and there's a trend towards less. And it's related to fewer procedures and tests and increased satisfaction. So what more is there to ask? We received the $9.6 million, and we were able to show similar outcomes. So a decrease in the mean length of stay by about 30%, a reduction in 30-day readmissions from the acute phase, which is a big factor for payment payments to hospitals at this time. They really look at that 30-day readmission rate. 19% increase in patient satisfaction, and 93% of patients were able to complete their acute care treatment. So that means they did not require or elect to go back to the ED or the hospital for additional workup and things we couldn't perform in the home. So moving into the future now, we are, in a joint venture with a company who helps us contract with insurance providers. We're trying to align our supply with demand. So we need to figure out how many people do we need on our team? What should our vendors look like? How broad can we go, considering geography, and then the regulatory compliance that comes with home care, which I'm sure you are all very well aware of, but also looking at quality metrics that relate to hospitalization and how do we adopt those in this unique healthcare setting. We are looking at education, such as today, for early adopters or people who are groups that are interested in expanding their use. And then also we are really looking strongly right now. We received a grant funding from the Hartford Foundation to look at telehealth technologies and using them more and more. So here's an example. A 70-year-old woman, heart failure, CAD, kidney disease, presents to the ED, short of breath for 2 weeks, lower extremity edema and abdominal girth. She hasn't been adherent to fluid restriction and salt and medications. And she was admitted, within the last 6 months for CHF. She's given IV Lasix, and she's restarted on her home meds in the ED, and she's telling us she's got low mood, labile sugars, and urinary incontinence. She's got adult children and informal caregivers. She had an aide in the past, not now. She's pretty independent. She has a cane and a motorized wheelchair, and she's mostly independent with her IADLs, but we're starting to see things flip. She can't take care of her housekeeping and laundry, and she's starting to need help with finances and shopping. She's not febrile. She's a little hypoxic with ambulation, but she's pleasant. She's slightly withdrawn. Normal heart sounds. Trace crackles at the bases when we listen to her lungs, and she's got some pitting edema on her legs. She has a mild kidney injury from, what's going on with her heart, and her troponin, which is tells us how her heart is doing in terms of blood supply. It's trending down, which is good. Her BNP, which tells us sort of how much fluid is overloading her heart right now, is actually elevated. So that means she's got a lot of extra fluid on board, and her chest x-ray is consistent with that. But nothing on the EKG to tell us she's having something more dangerous, like a myocardial infarction. So we need to think about, in her case, does she qualify for our program? And for us, she needs to live in the community, not in a nursing home or any sort of skilled nursing. Her residence is in Manhattan, and we take some zip codes in the Bronx and Brooklyn as well. She's got to be of adult age. We did have, and we were looking at pediatrics as well at this point. She has to have a contracted insurance provider, because now we're in our business phase. And one of the diagnoses we typically take, like community-acquired pneumonia, cellulitis, acute decompensated heart failure, COPD, dehydration, urinary tract infection, mild sepsis, and we take more than this, but these are our general trends. We're actually to 250-something DRGs right now. The exclusion criteria we need to think about in her case are arrhythmia, if she has severe valvular disease, which is causing this, respiratory distress, unstable angina or a myocardial infarction within 3 months, or the need for telemetry monitoring. So ineligible patients for hospital at home programs really do experience more clinical complications. And so it's really important to keep in mind the exclusion criteria and not take patients home that don't belong at home. Hospitalization at home for this patient really aligned with her values and goals. And she met our inclusion criteria. She had the right diagnosis. She didn't have any of the exclusion criteria. So we took her to our team. We gave her our plan was to give her IV Lasix, 80 milligrams twice a day, with simethicone, which helps to boost the Lasix. Daily labs, weight, physical exams, and assess her urine output, and reinforce her dietary indiscretions, try to keep her from them, and performing a med rec at home, which is really quite impressive. I know that a lot of your nurses will know that once you get home, what's written on the piece of paper is not what you see in the cabinet. This is what a day would look like. So the nursing visits would happen a couple of times a day. The provider visits, which could be an NP or an MD, would happen daily. Social work would usually happen once during the acute episode, and PTOT services are also very available and applicable in her case. And care coordinators who don't even have to really live here. So we have care coordinators in South Florida and Tennessee who do daily phone calls and use telemedicine to do such. And the partner services, in order to make a hospital work, are transport, lab technicians, x-rays, ECGs, telehealth, paramedics, So we have a lot of different partner services that we use in order to create hospitals, basically that are this hospital that's happening in a person's apartment or home. We have this ability to triage urgent complaints. So like every hospital, we need to have 24/7 availability. So the MD is on call. They can call at any time. We can do additional visits with our team during the day or urgent RN visits. We have a special arrangement with community paramedicine, which sends critical care trained paramedics to the home. And they can have a telemedicine call in the middle of the night with a physician, give a liter of normal saline, call me back, get an EKG, there's chest pain, give some nitroglycerin. We can do all sorts of therapies without having to transport them back to the hospital. And they have the ability to do some of those diagnostics. We always have the option with them to place the patient on the ambulance and bring them urgently to the ED if they're having something going on at home that requires hospital level care. So here are the case visit synopses. The RN went to see the patient, the physical therapist, the social work, and we administered the therapies. We got the labs from the RN. She saw a lot of the inappropriate medication taking and other barriers to her care, like her hospital bed. It needed replacement, mattress. She noted the depressive features and was helping with a lot of education. Physical therapy saw the decreased endurance, strength, and impaired gait, and recommended skilled PT to improve those. Social work saw inadequate home care, placed the referral for the home health aide, noted food insecurity, and helped with home delivery meals, got that replacement mattress with the DME needs, discussed psychotherapy and additional support for depression, and direct sign-out with a social worker at the primary care clinic. So wrapping it up, the patient was on our service for 7 days, which is a bit longer than usual, but that's par for the course sometimes for patients who need a lot of education and a lot of extra services to really be tucked in and secure. Home health aides were established, the food security addressed, the DME needs addressed. She got her referral for PT, and we transitioned her back to her primary care provider and heart failure specialist, and we continued to follow her for 30 days to help her not need to go back to the ED. So our transitional care model is under what we were trying to get for all of our patients, and it really requires insurance company buy-in, is a 30-day post-acute bundle. So basically, we keep on following them. We stratify them between standard and high-risk groups. We follow them, potentially daily, especially that high-risk group, with phone calls, home visits, making sure they get their home health aid services and additional nursing services during the transitional phase, and that they're seamless and they're occurring, those visits. Social work, health coaching. We have the 24/7 MD phone coverage with the community paramedicine to try to keep them out of the hospital, and a lot of communication with PCPs and specialists. So what really is the future of this model? Where do we see it today, and where is it going? Today, we have hospital at home all over the U.S., but the models look different depending where you are, and they're all there's no one size fits all. Every community, every group of people sort of has their own risk profile. So what we're doing here at Mount Sinai looks very different than Presbyterian, but what we see is that hospital is moving from hospitals into homes in a lot of different places, and the interest is only growing. And this is a picture of Bruce Leff, who I've had the pleasure of working with and collaborating with. He has noted that systems that are operating above capacity, have an innovative spirit, or total risk on a population, are likely to want to offer hospital at home. And if you already have the developed home health assets, such as your group, Caring People, you have a lot of home health assets. So if you compare the service to the need, it's a real opportunity here. The current challenges you're going to be facing here, that we're all facing that are in hospital at home, are the lack of a CMS payment model. So we can't take these dual eligibles. We can't take straight Medicare right now. There's quality and safety concerns. So we talked a lot about inclusion and exclusion criteria. How do we make sure that our patients are safe, and how does it compare when you're trying to streamline your quality metrics between two totally different realms the hospital inpatient side, so those quality metrics, and the home healthcare side. How do you recruit properly? How do you account for differences in your populations? How do you deal with refusals? How do you build your referral base? And then you want to think about recruitment, geography, your vendors, pharmacy, your capacity when you're developing your models. This is my mentor, Dr. Sue. He's really quite a visionary in the world of hospital at home and how to make this a viable business model. Our team has proposed a method of reimbursement through CMS to CMS, and is working with Congress as we speak. But this is going to take a lot of time. We have been working with commercial insurers and a venture capital firm. We're talking about startups and partnering, and we work with our ACO for our patient base. And other ways of getting to hospital at home are through innovation grants and those such. We're expanding the scope of what we do at home, thinking about packaging, subacute rehab following hip replacement, etc., technological advancements, and improving accessibility across the board. So we're really optimistic about what we can achieve with hospital at home in the U.S. And it's a model that's really used internationally at a much higher scale. We're excited to bring it here. So does anybody in the audience have any questions for me?
Hi, Dr. Davenport. This is Angela. I always have a question. I can't help but wonder when these, potential hospital at home patients come into the emergency room, how the physicians and the clinical team there, are willing to quote unquote let go of this patient and let them go back home. Have you met resistance in getting the physicians and the, practitioners on board that are in the emergency department?
Well, that's a great question, Angela, and thanks for asking it. And I do want to note that I'm also the person who always has a question in the room, so I really align with that. So what's really important for getting a hospital at home system to work is to make sure that leadership is on board with your method of care and believes in the service itself. If you don't have leadership support, you don't have much of a leg to stand on when you're doing sort of this sidebar, one-on-one, interaction, bringing a patient from the ED to home. But what I would say is there's a lot of excitement around hospital at home here at Mount Sinai. We see a patient that's possible, and usually when we're working with the primary team or their specialists that are teeing them up, we're having a really honest engagement about, okay, well, these are my capabilities. What do you think about telemetry? Do you really think you need it right now? Right now, we don't have the capability of telemetry at hospital at home. And so oftentimes it's sort of a back and forth. It's a really collaborative experience. I think everyone at the end feels very positively when the patients are going home on the ambulance. Or if we have to say, nope, it sounds like we really need that pulmonary consultant to see them again tomorrow, let's keep them here. So as long as it's collaborative relationships that you build and it's very transparent and there's leadership support, we've had a lot of great engagement. Any other questions?
Thank you. Hi, this is Maria Dimitriadis from Connecticut. We have a company called Remedy here in Connecticut, and they're in some hospitals such as Griffin Hospital. And they look at the bundling and the outcomes and all of that. Can I ask you, in the New York territory, do you partner with them or try to make inroads, or do you deal with the hospital end opposed to the company that's doing the third-party bundling?
So describe a bit more for me what Remedy's role is. So
what they basically do is they look to make sure that, all the DRGs are in order, to make sure they look at, the rehospitalization rates. And Eric, if you're on the phone, or Kim, can you maybe give a little bit more information on what their role is?
Remedy partners as a convener for bundle payments. So they work in bringing the organizations together and helping them, achieve success in their bundles.
Right. Yesterday, Yesterday I was at Griffin Hospital, and they have Remedy there, and they're only focused on exactly that. So how do you align yourself with that type of company that does that? Do you, or you do not do that?
Yeah, we do work with a venture capitalist firm based capital firm that is that helps us to develop our relationships with insurance companies. Since we're outside of the hospital model, we are not paid with the same bundle as what Mount Sinai itself gives. Although we are included under their ACO, for those patients, we're able to take them. And so within that, we need to develop relationships with other big companies like Humana, United, and so we work with a venture capital firm that is looking at putting together all of the hospital at home systems that they can gather into one group, and then with that group, they're able to create contracts in a bigger scheme and a larger scale, and so for hospital at home, which is specific. It's its own sort of entity. You sort of need to work with groups that understand the nuances of our system. And I think that probably Remedy is an inpatient team that helps out with bundling outcomes. But what we do is we do one-offs between our leadership, the firm that we've hired, and the insurance companies themselves.
Okay, that makes sense, because it's my understanding, like, I don't mean to labor on this, but yesterday when I was there, they said that this company strictly looks at all the rehospitalizations that are coming into Griffin Hospital. They look to see if, the team there, the case management team, is doing the right things to, once they discharge the patient at home, to make sure that everything's in place, so they don't get dinged on the rehospitalization going forward.
Yep, and that's part of our payment model, is, what we're responsible for paying for during that 30-day post-acute bundle. So absolutely. Okay. We try to model similarly the same sort of quality metrics that hospitals are utilizing.
Okay, thank you. Just for my own clarification, that's why I was asking you this.
Thanks, Maria. This is Adina. We probably have time for one more question. I don't know if anyone else has one more question. Anyone just itching? Needs to get it out?
This is Lori. I have a question. I know you said that you're not getting any reimbursement from straight Medicare, so have you had any success with managed Medicare, or were you referring to Medicare as a whole?
Yep. We are working a lot with managed Medicare. So that is our ideal population while we're working directly with insurance companies. So right now, that's precisely the population that we're very focused on. But there are additional groups within each of these insurers that we also are contracted to take on. But it's really the straight Medicare and the dual eligibles that we're hopeful that we can get this payment model through the federal government, because that will really open the door for really justice in terms of getting hospital at home, making it available to as many people in the population as possible. And I think that's a major focus for a new model of care, especially one that could really help decant overfilled hospitals, help with, preventing bounce back hospitalizations, keeping people aging in place, and most importantly, keeping them from being estranged from their loved ones as they age. We're seeing more and more people are hospital dependent. They have chronic medical illnesses that relapse, require hospitalization for their survival. And if we can achieve these things in their homes, they're able to see the birth, the grandkids, they're able to be there at the birthdays, they're able to participate and be a part of their families instead of seeing them institutionalized and really estranged from them. So that's the hope, is that we can create entire platforms of care that keep people at home. And I just want to say thanks so much, everybody, for being great listeners and having awesome questions. And it was such a pleasure to give you a talk today.
I know I speak for the group to say thank you so much. A wonderful presentation, really give us a great overview and lots to think about from a home care perspective. So thank you very much for your time this morning as well.
Thank you again. So interesting. Appreciate it very, very much.
Thank you.
Thank you. Have a good day.
Thank you.
Bye-bye.